All right, well, welcome to your final exam review. Woohoo! You've made it. Can you two see? Because I actually need my screen so I can navigate. Okay, it's being recorded too. The purpose of this review is to let you have some input, not all, some input on what you will see on your final exam. Now, even though that might make you feel special, I've been doing this long enough where I can say with great confidence, you're probably going to agree to the same material that 14 years worth of students before you have also said, hey, this is what I think should be on the final. So when you get your final exam, here is what you can expect. It will be organized according to units. So when you get it, it'll say at the top, Unit 1, and it will list these lectures. And as you go through the exam, you'll come to a change in font, and it'll say Unit 2. And Unit 2, I'll list what PowerPoints you had in Unit 2. For some reason, and you get the idea for Unit 3 and Unit 4. For some reason, this puts you in your happy place. Helps you collect your thoughts in your head. It's almost like you could flip through your PowerPoints unit by unit. So you're welcome. Now, here's our task. You will have exactly 2 hours to take your test. You do not have 2 hours and 20 minutes. You have 2 hours. That's the length of a final. I try very hard to keep the length of the final anywhere between 90 to 100 questions. There will not be a relationship. There will not be a word spell. It is going to be 100% Scantron. So 90 to 100 questions. It does not mean that we have to have roughly 25 questions from every unit. Some units might have more questions associated with them than others. And as we go through this little overview, I'm sure you'll start to appreciate why some units are more clinically dense than others. And that's our goal. We're going to go through unit by unit. I'll pull up PowerPoint after PowerPoint, and it's recorded. So if we get to a slide with material that we say, hey, that's really important, then it's recorded. You could hear that. You could see what slide, and here's what I recommend. You divvy yourselves up. You form a final exam study group in this regard. You might say, hey, the three of us over here, we're gonna do Unit 1, where your job is to go and pull the slides from Unit 1 and compile them based on what we said was clinically important. Then another group says, okay, we'll do Unit 2 and we'll pull the slides from the PowerPoints. And then another group says, we'll do Unit 3, and another group Unit 4. And then you email them to each other, and then you've got just a packet of slides that we agreed this is clinically important and could be on your final. Does that make sense? That's just my advice. You do not have to do it. You do not. So I'm not going to pull up the gene expression PowerPoint. Here's what you should know from that for the rest of your life. Those are my two favorite words. And where does it occur? Where does translation occur? What do you begin with? What do you end with? Good? Okay. Then what about homeostasis and thermoregulation? 5 years from now, think of yourself working in a healthcare environment 5 years from now. If I cross your path on the sidewalk 5 years from now, what do you think is the most clinically important material from this PowerPoint? Clinically important. I don't think we need to put language of the discipline. I don't think we need to. If you really need to review what a deviation is and a correction is, you should probably repeat the class. Thermoregulation is, of course, important. But out of all of that, what is the most clinically important for thermoregulation? It is controlled through negative feedback, and we use thermoregulation to introduce that idea to you. But fever is clinically important, right? Fever. What can we say about fever? Its set point is changed. Remember, that was very different than exercise-induced hyperthermia, or the term hyperthermia in general. So by studying fever, we are also studying the language of the disciplines: set point, deviation, correction. Do you remember what COX inhibitors do? What changes set point for our body temperature? What is it at the molecular level? PGE2. And COX inhibitors prohibit the COX enzyme from initiating that process of making PGE2. So maybe a question on fever? Yeah, we don't need 10, we don't need 5. 1-ish. Maybe 2 if we broke it up into deviation, set point, and then COX inhibitor question. I wouldn't expect more than 2, not at all. Next, body fluid compartments. Well, most of that was math-based, so there is no math on this, of course. What can we say is very important about body fluid compartments? Well, body fluid compartments, you should know your major compartments. You should know those. You're going to manipulate them almost hourly in a clinical setting. You should know how are they the same, what should be the same, what can be different. By the way, I'm doing this review also in mind for keeping in mind students in other classes. So if their professor runs out of time and can't do a review, typically the other professors and I agree on what we're going to have on the final, and this is basically what we do. What is the most clinically important? Clinically important, why does water move? Is it? Knowing why water moves? How it moves? I mean, I think I can test you on osmosis through Starling forces. Causes of edema, but that's later, isn't it? Hydrostatic pressure, well, that's blood pressure. That's unit 3. Yeah? So we'll wait on that one. I would just know your body fluid compartments. What's the one thing that they should all share in common? Their osmolality. Absolutely. Good. Okay, done. Endocrine. Very likely, you will come across a person who has an endocrine disorder. Very likely. So let's highlight some endocrine disorders which are hallmarked, I'll remind you, by negative feedback, inhibition, failure. That's where they go awry, remember? They have failure of negative feedback inhibition. Some classics, Graves' disease is a classic. Hashimoto's is a classic. Iodide deficiency is a classic. Now, Graves' and Hashimoto's, I'll remind you, are autoimmune disorders. So again, if you're compiling your slides, I'd compile this one for the Graves', this one for the Hashimoto's. It also has the iodide deficiency. But iodide deficiency, that's better. Iodide deficiency is different from Hashimoto's and Graves' in that it's not an autoimmune disorder. We just don't have the proper ingredients to make thyroid hormone. The way I taught it to my anatomy students was, if you want to make chocolate chip cookies, but you don't have chocolate chips, you can make a cookie, but you sure as hell can't call it a chocolate chip cookie, can you? So if you have iodide deficiency, you can make something close to thyroid hormone, but it's not thyroid hormone. It still will have negative feedback inhibition failure. The adrenal cortex is important, and I would review Addison's disease and Cushing's syndrome. Cushing's syndrome, very common. Reason is, you can have iatrogenic or physician-induced Cushing's syndrome, where the patient is given an exogenous cortisol pill. If they are removed from that pill too quickly, they can go into an Addisonian crisis. That's life-threatening. So I think you should review those two problems of the adrenal cortex. Remember, the only layer of the adrenal cortex that obeys the true HPA pathway is the zona fasciculata that releases the glucocorticoids. Done for endocrine. White blood cells and immune system. Micro does such a good job of that. They really do. So here's what I'm going to say. Can you look at the white blood cells and have an idea of what they do? Like, what does a neutrophil do? That's clinically important, that you have an idea of what they do. For example, we use these terms neutropenia, neutrophilia. What does that mean, penia or philia? Leukopenia, leukocytosis. When can a person have leukocytosis? Actually, these were words that were in your lab manual a long time ago. Penia means too little. So if someone has too few neutrophils, what do you think they're going to present with? What do? They're really good at fighting infections, aren't they? So if you don't have enough of them, guess what's going to happen to you? You're going to have opportunistic infections. When can a patient have leukocytosis? Is that normal? Leukocytosis is normal if they're fighting an infection. They would have elevated white blood cell counts. That would be appropriate. They're fighting an infection. But is it normal to have leukemia? No, which is still elevated white blood cells, T cells, B cells, but they're not well formed. They're not well formed. That's appropriate. To know your white blood cells, have an idea, just review what they do. Review your terms, penia, philia, cytosis. Too much, too little, what would your patient present like? And why is this clinically important? We draw blood all the time, and we are looking at the formed elements. If they are out of normal range, It might be that your patient is fighting an infection. If they're below normal range, they're going to be susceptible to infections. That's clinically important. Just that basic understanding of them. And something else that goes along with this would be blood typing. That's clinically important and has everything to do with the immune system. So please review blood typing. In Unit 1, it said, when you had the blood typing lecture, it was under the lab unit, and it said it was up to your teacher's discretion to either test you on blood typing on the lab exam or in the Lecture 1 exam. And I tested you on the lab exam, but I am going to test you on blood typing on the final exam. Who can donate to whom? Who are we worried about when we give a blood transfusion? Who are we worried about? The recipient or the donor? Why? What do we do to the donor's blood before we give it to the recipient? We remove the plasma, which has what? Antibodies. See, that's our immune system, right? That comes back to the lecture on white blood cells that we need to keep that in mind. It is clinically important. I don't care about the different kinds of receptors on T cells and B cells. I'll let Micro abuse you with that. Just have a basic understanding of what the white blood cells do. What do those words mean? Pinia, philia, cytosis. And review your blood typing. If you go back to your lab manual and do the practice problems in the lab manual from Unit 1, you're set. You're set. Okay, what about erythropoiesis and red blood cell destruction? Can you remember what hemoglobin is? Do you need to study that? Hey, it's in Unit 4, so if you need to study that, it's in Unit 4, which will be on the Unit 4 portion of the final exam, because it has everything to do with oxygen hemoglobin dissociation curves. So I don't really need to pull that from here. And if you can't remember what a hemoglobin molecule is, then probably you should repeat the class. Anemias are clinically important, but let's whittle it down. What is the definition of anemia? Decreased oxygen carrying capacity. Hey, that's in Unit 4 as well. Yay. So we come right back. What is a very common anemia that you will likely see in women? Iron deficiency. What will the cells look like? Small, good, microcytic. So review those terms, microcytic, hypochromic. Remember, they're not going to be well filled either. You don't need to worry about MCV, MCHC, blah, 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 blah. Just tell me the hallmarks of iron deficiency. What's another common one? How about hemorrhagic? That's probably pretty common, especially after surgery. What would those red blood cells look like? Huh? Are they not well formed? They are? What's wrong then? You just don't have enough of them, or they're on the floor, right? They're on the sidewalk and not in your body. Okay. How about megaloblastic? How about those three? Those are pretty common. We don't really need to worry about hemolytic because, hey, blood typing is on the exam. So, see how that got threaded in there? Turnover of red blood cells is important. Your patients can have jaundice. It's not just jaundice of a newborn. Adults can have jaundice. Please review your jaundice slide. Conjugated versus unconjugated bilirubin levels. Both, if elevated, can lead to jaundice. Who is more likely to have jaundice from unconjugated bilirubin being elevated? They're a blend. So I'm speaking specifically of just unconjugated. I'll give you, huh? No. Well, yes, but I was going to give you another hint. When I went to my old person aerobics class the other day, all the seniors, because I thought if I went to a senior citizen aerobics class, they'd be less intense and not so crazy about their territory in the classroom like people my age. Oh no, they're worse. They're worse. That is my spot. Okay, that is Trudy's spot. Okay, that is Marilyn's spot. Okay, that is Sheema's spot. All right, I'm just gonna be over here in the trash can. I'm just gonna stand in it. But they were all a Twitter talking about Harry and Meghan's baby and how the baby clearly has her skin color. And I was like, I saw those pictures too, and I'll call bullshit because the baby is about 48 hours old. And who is very likely to have unconjugated bilirubin resulting in jaundice where they look like they have a suntan? Babies, newborns. Why? Their liver isn't mature. Good. And then conjugated bilirubin, who is most likely to have that problem? Someone who has a bile duct obstruction, like a gallstone. Now, alcoholics will have both. They will have both. They will have the kwashiorkor, which obstructs the bile duct, if you remember. And their liver is failing if they're severe alcoholics, so they won't be able to conjugate the unconjugated to the conjugated. Done with that one. Clotting. Oh boy. That's pretty dense, isn't it? That is definitely clinically important. So switching. There we go. Do you know what a platelet is? Let's start with that. I think you should. What are they? They are formed elements, but what's in them? What's in them that makes them so well suited for clotting? It will not test you on the different phases. That's not really clinically important. It's really not. But the manipulation of hemostasis is definitely clinically important. So, please review heparin, coumadin, protamine, and vitamin K. What clotting factors require vitamin K? 2, 7, 9, and 10. Heparin works immediately, remember? Immediately. To reverse it, we need to put in protamine. Protamine basically removes heparin from antithrombin 3. Antithrombin 3 and heparin, when they are together, they extend clotting times. They make it longer for the blood to clot. Remember those words. Clotting times lengthen versus clotting times shorten. Coumadin, remember, competes in the liver. It will not work right away, and it competes in the liver for the same binding spot as vitamin K. So if someone has liver failure, we can give them an injection of vitamin K within hours, not right away, but hours, clotting factors 2, 7, 9, and 10 should be back up on board, back to where they should be for their activity. If someone is on Coumadin, why should they watch their green leafy vegetables? Because they have vitamin K. Okay. A thrombus. One more thing. If there already is a clot, what do we give? Will heparin work on a current clot? Nope. TPA, tissue plasminogen activator, right? Plasminogen is a zymogen. It has to be activated into plasmin. Plasmin, I'll remind you, is the clot buster, not TPA. Remember, that was one of our early misnomers that we talked about. All right, Unit 1 is pretty dense. Unit 1 is pretty dense. I would expect about 25 problems. Just get an estimate there. Yep. Yes, about 25 problems. It's clinically dense. Moving on to Unit 2. Dun, dun, dun. Do you think you'll ever be describing membrane potential? No. But do you remember that the inside of cells are negative? And do you remember the 3 big reasons why? And you probably won't be describing an action potential to a patient. However, let's be very honest. Those action potentials and membrane potentials come down to, for the most part, electrolytes. And that is clinically important. Heck, you just had a test on it tonight. And that also comes into our body fluid compartments, doesn't it? Where should we find sodium most abundantly? Or should we find potassium? So I would review action potentials. I would go back to Unit 2 homework packet where you had a picture of an action potential and you had to match descriptions to letters that were next to the action potential, like the upstroke, the downstroke, hyperpolarization. All of that is based on electrolytes. And if your patient has an electrolyte disorder, excitable cells, their function goes away. Now, the action potentials looked different for neurons. Neurons and skeletal muscle cells were similar, right? They were pretty matched. They just had different lengths of them. Muscle had excitation, contraction, coupling. Neurons don't have those phases. But when we got to Unit 3, action potentials of specialized cells and contractile cells looked very different, and we had calcium part of their action potential. Not an afterthought, it was part of it for both of them. So I would review your action potentials for your excitable cells. Neurons / skeletal muscle. Specialized cells, contractile. That is all centered around electrolyte balance. Clinically important. Let's talk drugs. No. Nope. Why? Most of you are going to take pharmacology. Fine, I'll let them abuse you. That's next. No. What about autonomic nervous system? Gosh, I really hope you don't need to study this. If you want heart rate to increase, which division? If you want heart rate to decrease, which division? Good. What are their neurotransmitters that are typically used? Epinephrine / norepinephrine for which division? Good. Can you rattle off some adrenergic receptors? Alpha 1, alpha 2, alpha 3, alpha 1, alpha 2, beta 1, beta 2, beta 3. What about parasympathetic? What neurotransmitter? Acetylcholine. What is its receptor? Muscarinic acetylcholine receptor. What would these divisions do to breathing rate and depth? I mean, if you need to study that, again, you should probably repeat physiology and anatomy for that matter. That's what I'm going to focus on for the autonomic nervous system. What receptors do they have? Not even second messengers. Zippo on second messengers. That's not clinically important. But the receptors for these divisions, they are clinically important. They are. And you did learn drugs that can block those receptors or stimulate them. I'm not going to have those drugs back, but you should remember their receptors. You should remember what they're going to do to heart rate, to respiratory rate. I mean, again, you should not have to study that too hard. Metabolism and digestive system. What's clinically important with that? I don't think your patient's going to give a rat's whisker what cell releases hydrochloric acid and what cell releases pepsinogen. But ulcers are clinically important. So how about you review ulcers? That's important. How can a patient get an ulcer? And there was a slide on the digestive system. Where we talked about that. Peptic ulcer disease, losing your protective factors, and if we rule out abuse of NSAIDs and alcohol and smoking, what was the most common reason why a patient got an ulcer? That guy, H. pylori. So ulcers are clinically important. Please review the slide on how we lose our protective factors, how Helicobacter pylori is implicated. And remember that the parietal cell does release hydrochloric acid, and it can be stimulated in 3 different ways: local, neural, and hormonal. And that kind of control, local, neural, hormonal, was a common theme starting from Unit 2 all the way through Unit 4. And this is a perfect application of that. There is one thing that unites digestive system with a metabolic lecture. There is. And it is clinically important, and it is very costly to our nation. It is a very, very rampant problem, diabetes mellitus. So review: diabetes mellitus, type 1, type 2. Please understand diabetes has been with us for more than one lecture unit. We learned about it for body fluid compartments in Unit 1. We learned about it in Unit 4, leading to diuresis and why. And in Unit 2, we learned about diabetes and how it is a nutrient mismanagement. It's not just a sugar problem, it's also problems with protein metabolism and fat metabolism, because we learned that if the cells can't get glucose into them and they can't burn it, can they burn alternative fuels? Well, they can't. They can't. And do remember, all roads, let me show you this slide. It was so simple, and most students just don't even pay attention to this slide right here. All roads for metabolism lead to the mitochondria. All roads. Protein, carbohydrate, fats. Entry point, Krebs cycle. What is the molecule that is 4 carbons long and is the entry point, beginning point for the TCA cycle, for the Krebs cycle? Oxaloacetate. And what's the problem with oxaloacetate? Where does it come from? It is a carbohydrate. So if you can't get glucose into your cells, either because you're resistant to insulin, or you're not making insulin, or your receptors are defective, or you are on a keto diet and you're not getting enough carbs in your diet, you're going to have a problem, and you're going to go into ketoacidosis, aren't you? Can you name the 3 ketone bodies? That's clinically important. Beta hydroxybutyrate, acetoacetic acid, and acetone. Which one of those is volatile? Acetone. The other 2 have to come out which way? Just had a test on it. Urine. Thank you. That's, digestive system, ulcers, diabetes mellitus. That's fair. Those are clinically important. That's fair. Okay. So for Unit 2, again, I would review, get off the paper clip so it's easier for me to review. I would review your electrolytes and your specific action potentials for your excitable cells. For Unit 2, that was skeletal muscle / neurons. I would review which way those electrolytes want to move, if they're allowed. That's important. Many of you tried to answer that relationship problem tonight. Let me gently say you should review potassium probably. And when we're talking about electrolytes, we know that they can disrupt excitable cells because it can lead to excitable cells either being hyperpolarized or depolarized, right? Too excited or not excited enough. That's what we're talking about. So I would review those terms, hyperpolarization, depolarizations. And And in that lecture, Dendrites to Synapse, in fact, there were 2 slides where we discussed how a cell could become more negative. Do you remember? We did. IPSP slide. Yeah, it was on that slide. We talked about that. We also talked about how cells could get closer to threshold, more excitable. Those were EPSPs, remember? Mm-hmm. And we also talked about that neurotransmitters frequently are said to be excitatory or inhibitory. Is it the neurotransmitter? No. What is it? The receptor. Good. So if a cell becomes more excitable, do you remember the language? It'll get closer to threshold. If it's hyperpolarized, it's inhibited, it's further away from threshold. Do you remember that? Okay. You will never be talking like that to a patient. I recognize that. But it is a good representation of understanding electrolytes across cell membranes. So for Unit 2, less than 20, 15 to 18. Unit 3. Unit 3, no more than 12 questions. Does that seem funny to you? Unit 3 is our cardiovascular system. Are you having a, what the hell? That's clinically important. Well, I know, but think about the part from Unit 3 that's clinically important. 1, blood pressure, hydrostatic pressure. It all comes down to Poisson's law. How can we lead to the fastest increase in pressure? Vasoconstriction, put more pressure in the blood inside. But what would that do to blood flow to an individual capillary bed if the upstream arteriole constricts? The amount of blood going to that capillary would go down. So remember from Unit 3, we had to have this separate conversation about systemic changes versus to a local capillary bed. So review Poisson's law. We used Ohm's law in Unit 3 as well. Remember, flow equals change in pressure over resistance. Do you remember what blood pressure numbers look like? If I say 140 over 90, I know it's high blood pressure, but what number is systolic? Do you remember those? Because I'm not too sure you do, and those are some simple questions. You know what? Baroreceptors are clinically important. We talked about the baroreceptor reflex arc. In lab, for crying out loud, you should be studying how we can manipulate it. So if you're studying your baroreceptors for lab next week, you're also studying for Unit 3. It's perfect application. And in fact, Lab Unit 2 has questions on blood pressure. You know that. So there you go. When you're studying for your lab exam, you're going to be studying for the most part for your cumulative final for Unit 3. Well, don't we do EKGs all day long?
It's really evil smile.
I mean, if I have a picture, lots of pictures of the beast, could you figure out which one's the correct picture of the beast? Let me help you with that one. When I taught you the beast, I said, you know what? I wish the picture of the beast was shown in a different way. It wasn't logical, I said. Not to me. And you went, I don't care. And I think the beast is a one-stop shop for Unit 3. I mean, it's got everything there. And the reason why I said I think it's not organized right is because I said electrical events precede mechanical. Remember that? How many times have I said that to you? You forgot because it's been so long, Unit 2 and Unit 3, when we were talking about excitable cells. So I thought we should have the EKG first. That's the electrical that's happening, the electrical event. Then the mechanical event is the pressure difference. Remember? We start to see contraction. And as a result of that, we start to see flow. And you learn that pressure and flow, or volume, I should say, were inversely related. If pressure went up in the ventricle, it was because the blood was being pushed out. So volume went down. And then you learned that if there was blood flow that was turbulent, what did we hear? Heart sounds, didn't we? And we also talked about when valves were opened and closed. So I would review your beast, and I would also review the electrical events and what mechanical events they would lead to. Not just for blood flow, but also opening and closing valves. Remember, those open and close because of pressure differences. That was also shown here in this slide. Unit 4. I don't need to spend a lot of time on Unit 4. Unit 4, there are approximately 34 questions. Why? Oh, there was a significant lecture that was omitted from tonight's exam. And tonight's exam was disproportionately focused on the renal system. So, my darlings, Unit 4 for the cumulative final is going to focus on those respiratory lectures. And if you have not yet looked at those 2 supplemental chapters with the end of the chapter questions, I suggest you do. The answer key is there on Canvas. And if you need help understanding why the answers are right, don't I still have a review on there somewhere for those supplemental chapters on YouTube? Did I do that? Or was that a podcast I did a long time ago?
I don't know if you had a review. I mean, I never looked for one. I always knew you had the answers for it.
Yeah. Anyway, if you need help figuring out why the answers are correct, I suggest you come see me sooner versus later. Next week, I will be having modified office hours. It's a weird week. Anyway, I will be posting them on Canvas for next week and also the week after. Okay? So please pay attention to Canvas.
Kara, so it's just on this one and those 2 supplements that you said?
No, there will still be questions from the work of breathing and mechanics of ventilation. Absolutely. Because, for example, in that one, Fick's law was discussed in detail. you should use Fick's Law and go back to the lecture on the work of breathing and explain how a person with emphysema has trouble with Fick's Law. What part of Fick's Law is their issue? Surface area, most notably, is a problem. Higher levels of CO2 is a problem. That means lower levels of oxygen. Fick's Law talks about pressure gradients. So I would go through those disorders of breathing with Fick's Law by you and say, what part of Fick's Law is their issue? Oxygen hemoglobin dissociation curves, for sure. There are definitely questions on Dave Shaw, Don Shirley, Dion Dreyer. What gases were their issue? There will be a matching section on gas laws to the person who studied them, like Dalton, Henry's, Boyle's. Wasouillet still was applicable in the respiratory system. I would review your terms like what is oxygen carrying capacity versus oxygen content. And how do we measure them? What do we need? There were a couple of times where I even put it on the board. I would also make sure that you don't get confused with what is a carbamino compound? Like what is carbaminohemoglobin? What's carboxyhemoglobin? What's methemoglobin? What's oxyhemoglobin versus deoxyhemoglobin? Central versus peripheral chemoreceptors. What do they respond to? Remember, peripheral, they respond the most to oxygen, but how far does it have to dip before they signal the brain? Below 60. It's pretty far. Remember, look over your 4+1 for your oxygen hemoglobin dissociation curves. There's a lot on oxygen hemoglobin dissociation curves. I would also make sure you know the symbols that I gave you. What is little p, capital A, capital O, O2? Remember that? What's little p, little a, O2? Partial pressure of oxygen in the alveolus, partial pressure of oxygen in the arterial. And some of those questions from those 2 supplemental chapters I gave you, they don't use the symbols, and they have to describe what partial pressure of oxygen you're looking at. Are you in the alveolus? Are you in the arterial? I will be using the symbols, so you should know what they are. Yeah, work of breathing, surfactant lack, so restrictive versus obstructive disorders. Anything else you want to add? Well, sometimes I've had classes going, no, yes, I think this is really clinically important. I'd be like, wait, what? Shock. Yeah, that is important. You're right. Hypovolemic, neurogen, and I'm like, it's important, but it's not going to be a like everyday thing that you would see. It depends on where you're working. Then some student will go sheepishly, Starling forces, and then the rest of the class goes, shush! And that's where I go, weren't you abused with those enough in the last 2 lecture units? I think we're done with that. Anything else you want to add? No? And what about it? Yes, and? Okay, well, that's what I have for the final exam. Good. Okay. Stop my video.